Yeah, I think we're good to go.
Okay, good evening, everyone. It's an exciting day because I think for the first time ever, today you get to hear Joseph discussing a case. I think he has been waiting for this day forever. And I kept telling him I'll be discussing cases, but finally the day has arrived. Because of some tight schedules, I did not prepare a real case from our setting. But I'll present a human DX case for him today, and I believe maybe next weekend onwards, I'll have a few cases from our setting for Joseph. But nonetheless, I think you'll enjoy learning from Joseph today. So, Joseph, I have a case for you, and if you are ready, you can tell me so I start presenting.
Yeah, sure, you can start.
Okay, so our case today is we have an 80 years old female presenting with increased frequency of urination.
Okay. Um. Yeah. So thank you. That's a chief complaint that we usually, yes, I can say we usually see. And do I have an approach? So this is an elderly woman who is telling you they have increased the frequency of urination. Yes, I have an approach. So the first thing I should ask, if I'm seeing this person maybe in my clinic, they're telling me they're having increased the frequency of urination. There are two things there. It's either the volume of their urine has increased, that's why they are going frequently to urinate, or that's not the case. Maybe the urinary system is just inflamed because of, let's say, a UTI. That's why they're going to urinate frequently. Not that the volume has increased, but just the frequency alone. So if it's the frequency alone, that's easy. It's a woman, elderly, straightforward. One should be thinking of a UTI, not many other things. You order urine analysis or ask other symptoms of UTI, such as dysuria or mesopubic pain, and then you realize what you're dealing with. But the other problem now, if the urine volume is increased, now this will be a bigger problem because you'll be translating it as polyuria now. And if you define it scientifically, polyuria is when you have 3 liters of urine per day. So in all comers, you have seen, when you're seeing someone that's telling you they have polyuria, you all have seen diabetic patients presenting with asymptomatic diabetes. They have polyuria. But is it the only thing? The answer is no. So there are other things. So if this case will turn out to be a polyuria, I will approach it into two ways. Is the volume of urine increased just because there are a lot of water in the urine, or is the volume increased because there are a lot of solutes that are pulling in water and they're going out? These are two different entities. Because now, if you define it now clinically, you can say water diuresis and solute diuresis. Solute diuresis is what like we see in diabetes, which is not difficult. But there are other things. Someone who has been given mannitol, they will present with polyuria. Someone who have been given 3% saline, they can present with polyuria. All these are solutes that can suck in water and come out with a lot of water. But on the other hand, if they are having a lot of water without a lot of solutes, that will be a different problem. And in that category, the first thing to think is one, diabetes insipidus, as you know it. and the other is maybe somebody's drinking a lot. So why should they be drinking a lot in such a way that they are having 3 liters of urine per day? So maybe they have a primary polydipsia. They have this is a mental illness which tends to make them to drink jugs of water. So I'll be hearing other things which are there. Maybe you are telling me they have been diagnosed diabetes, or you're telling me they're using lithium, things like that. I can channel my thought into that thinking. Thank you.
Okay, already very interesting. I think everyone is enjoying. So this patient,
No. David.
that's
Um,
I adjusted the complaint. So the first, yes, Joseph.
yeah, I think now I can hear you. Can you repeat what you are saying? I think you cut out a bit.
Okay, no problem. So I did a little adjustment. I modified the complaint. But as you are presenting, I think your approach is very clear. So this patient uh, presented with increased thirst and urination for several months, and this has been progressively getting worse. And the thirst is worse in the morning when she first wakes up. She has to drink several glasses of water before breakfast, and often gets up at night to urinate. She reports no weight loss, no history of head trauma. So that is the first aliquot.
Okay. Yeah. So
Yes. So,
yeah. So the information again falls into what I was discussing before, because what we are told in this aliquot is that this person is also drinking a lot. Yes, because they are losing a lot of water. So this means their thirst centers are working quite well. They are telling this person, you are losing a lot of water through your urine, so drink more water. No history of head injury is particularly important, because now uh, thirst centers, uh, central diabetes insipidus, these things comes from the brain. So that's why they are telling us about the history. I think we can proceed and hear the history.
so the past medical history, the patient has was diagnosed with prediabetes, uh, disequilibrium, COPD, as well as sleep apnea. And maybe I should just join that with medications. She's on aspirin 81 milligrams daily, vitamin B12 1,000 milligrams daily, vitamin D 2,000 international units daily, magnesium 200 milligrams daily, omeprazole 20 milligrams, meclizine 25 milligrams, PRN for dizziness. Maybe you can discuss those.
Yeah. So the the past medical history is quite interesting as far as diabetes is concerned. They said they have pre-diabetes. So a next thing to do is to ask, okay, they had pre-diabetes. Maybe did they progress into full-blown diabetes and they are presenting with symptoms of severe hyperglycemia, the polyuria, polydipsia, and polyphagia, or is it another thing? And that's simple. We can know when we do the RBG, the finger stick glucose. On the part of medication is very important here, but still, I don't see any medication that I should. Maybe meclizine. Tell me about meclizine. What is this?
Also, I do not have much details about it, but it's a medication. I'm not sure about the mechanism of action,
Mm.
but used mostly for patients with dizziness.
Uh huh. Okay.
Yeah,
Sure.
yeah. Maybe as you are discussing, I'll try and check and see the mechanism of action and all that, and come back to you if there is anything interesting.
Yeah, I've never prescribed such a medication. And yes, the other past medical history apart from prediabetes, you said she has what else?
COPD.
Mm,
I saw there's pre-diabetes, disequilibrium. I think that's the reason for the mechanism.
okay.
COPD as well as sleep apnea.
Yeah. Yeah. So COPD, maybe she had previous history of smoking. We'll hear in the social history, which is important as far as DI is concerned. And the disequilibrium, uh, it is not well elucidated because it is presented as someone presenting you, she has anemia, which you don't know why. So this disequilibrium, why should we have disequilibrium? Someone can translate it into ataxia, for example. But even someone with weakness, they will walk with disequilibrium, or they have maybe inner ear pathologies, which are making someone to give this mechanism. Uh, no one knows for sure. I think we can proceed and hear another history and see if we can integrate it with what we know now.
Okay, thank you, Joseph. So I think it's some 10 minutes since we started. I'm not sure if there are many new people who have joined, but maybe you can just summarize a bit so we can be on the same page.
Yeah, so we are discussing a case presented by David from Human DX here, about a 80-year-old female who is presenting with frequent urination. And so far, what we are told is that she has some past medical history of particular importance is pre-diabetes, also disequilibrium, and that she is on some meds, which include aspirin, B12, vitamin D, magnesium, omeprazole, and the meclizine for disequilibrium. Yeah, and we are proceeding.
Okay, so the next aliquot is on initial labs, so they do not have any further history.
Okay.
On initial labs, we have a glycated hemoglobin of 6.4, and the reference range is 4 to 6. A TSH is 2.4, the reference range is 0.24 up to 5.6, so it is within normal range. Complete blood count as well as basic metabolic panel are normal. Urinalysis normal, and 24-hour urine volume is 5,000 mils. So that's on initial labs. If
Yeah,
you have anything there.
yeah. So yes, now we are getting a good picture here. We are given a HbA1c, which points to the prediabetes, which we are told in the past medical history. So this patient doesn't have diabetes, and the frequent urination that she's having is not from diabetes, which is most common, by the way. So we are moving into some few esoterias, by the way. And other labs that you're telling me, a TSH was normal. I'm not surprised. A CBC and BMP, they are normal. So when they're telling me of a BNP, I believe they include things like potassium chloride, sodium, creatinine, and other stuff. And of particular importance is the sodium. So this patient is urinating a lot, is drinking a lot of water, and then their sodium is still in the normal limit. What does this tell you? It tells you this patient's thirst center is functioning normally in such a way that it can sense that the sodium is low and tell this patient go and drink water. If you see a patient with polyuria and they're having a low sodium, your translation should be this patient, either the thirst center is not working well, maybe they have some pathology, maybe the
Joseph, I'm not sure if it's my internet or yours. You are breaking at some points.
okay.
Yes, so maybe you can repeat what you are saying because, yes,
Yeah. How about that?
yeah,
Yeah, okay. I was particularly discussing about the fact that the HbA1c of this patient is not
yeah,
elevated.
it's clear now. Maybe you can reiterate what you are saying.
Okay. Yeah. So let me start over. I was discussing the labs that you presented, and find two things to be very important. One is the HbA1c of 6.4, which points to the prediabetes that this patient is having, and is telling us this frequent urination, it is not from full-blown diabetes, probably. And again, the BNP is normal, and in this BNP, sodium is included. So I was trying to provide a teaching point here. If I see someone with polyuria, they're drinking a lot of water, they are peeing a lot, and their sodium is within normal range, it tells me their thirst center is functioning well, because it tells them, um, you are drinking a lot of water, your sodium gets diluted, you are losing a lot of water, which makes sense. So if you are seeing someone with polyuria and they're having low sodium, it means two things: either their thirst center is damaged for whatever reason, whether genetic or acquired, or um, uh, they cannot access water. Like someone is, has polyuria, they're in the ICU, they cannot wake up and access water, they're unconscious. I've seen that. I was rounding in the ICU when I was in, I think, MD3 with Kiara. We saw a guy has a lot of urine, very high sodium, and then we realized this person cannot access water. Is just sleeping here. Or kids. So the children like 2 years old, they are having polyuria. They cannot access water, so their sodium will be abnormal. But this patient, their third center is working well, plus they can access water. The urine volume of 5 liters per day proves our point that this urinary frequency is because of increased urine volume, and probably not the solutes. I mean, probably not because the urinary system is inflamed from a UTI. Sorry. So we are dealing with polyuria here, guys. And as I have explained previously, when I approach polyuria, I think is this from solutes that are being excreted in the urine, or pure water. And to proceed from that, the solutes we have just mentioned some of them. We said sugar from diabetes, which is not the case here. We said some mannitol, or 3% 3% 3% saline, which is not the case. We're not hearing that story. Or even someone who is having a very high urea. If you see someone with aki, they have very high urea. When they are coming out of that aki, they'll produce a lot of urine, because they have uh, a very high urea, which also can pull water from the tubules and come out with it. But I think we are not dealing with that here. What we are dealing with here, I believe, is a, is a, is a water diuresis, as far as I can tell. And water diuresis, two things: primary polydipsia, which is not the case, because you have to drink a lot to produce something like this, and then diabetes insipidus. And if we can move further into this, what I'm thinking, diabetes insipidus can be central, peripheral. We'll hear from the story where we can localize the region of this lady. More records, maybe.
Yeah, thank you, Joseph. So I think we have two more records. So the fifth one is so they did a 3-hour fluid deprivation test in the outpatient setting from 8 a.m. to 11:30 a.m. I think that this is not a very common test we come across. The serum sodium was 140 at hour 0, 141 at hour 1, and 144 at hour 3. And the reference range is 135 to 145, so the normal serum sodium levels. And then serum osmolality was 304 at hour 0, 309 at hour 1, and again 309 at hour 3. And the reference range is from 278 to 305 milliosmoles per kilogram. And then if I'm presenting fast, you can tell me to read it or slow down, Joseph. And urine osmolality was 183 at hour 0, 203 at hour 1, uh, and 191 at hour 2, again 191 at hour 3. And the reference range is from 40 to 1,350 millosmoles per kg.
Mm-hmm.
Yeah, so that is
Yeah.
one. That is before we have one alquote remaining before revealing the final diagnosis.
Yeah. So I think maybe you were at the internet. Maybe you can repeat that record. I was not hearing well the numbers and the reference.
Okay. Yeah, so this was a 3-hour fluid deprivation test, which was done in the patient setting
Mm.
from 8 a.m. to 11:30 a.m.
Mm-hmm.
Yeah, so the serum sodium was 140 at hour 0,
Mm.
141 at hour 1, and then 144 at hour 3.
Mm.
And the reference range is 135 to 145.
Okay.
Yes. So the second is the serum osmolality,
Mm-hmm.
304 at hour 0, 309 at hour 1, and 309 at hour 3.
No.
Reference range is 278 to 305
Okay.
milliosmoles per kilogram.
Mm.
And then urine osmolality was 183 at hour 0,
Mm.
203 at hour 1,
Mm.
191 at hour 2,
Mm.
191 at hour 3. And reference range is from 40 to 1,350 millosmoles per kg.
Okay. Now, so you can correct me if I'm wrong. So what it means is the urine osms are low, right?
Uh, urine osmolality 183. Okay, so the reference range seems that urine osmolality is within normal range.
Urine osms within normal
From
range.
Yes, so from 183, then 203, then 191, 191. Our reference range is from 40 to 1,050.
Okay.
I mean, 1,350. Yeah.
So urine osm is in normal range,
Yes.
and the serum osm they are high.
Yes. So at our 1 and our 3, serum osmolality went slightly above the normal range. So upper limit is 305. It went to 309.
Okay.
Yes.
Yeah. So yes, as you're saying, this is I've never done this. I tried to do in that patient that I told you in the ICU, and if Kiara is here, if she remembers, we couldn't. Send the lab, and the lab said, "We don't do that here. You should collect 24 hours urine," and then the patient died the next day. But I should use a common sense. Um, so this person is losing a lot of water and is drinking a lot of water again. But in that same sense, they they their serum osms, which shows how concentrated their serum is high. So that is not troublesome to reflect, because that is what should happen. You are peeing out a lot, so your serum osms is going up. Now, what is troubling for me is this urine osms, which is within normal range. So, if this patient, let me go from what I was thinking the differential diagnosis, because the differential diagnosis are just very few here, and I can reflect from them. I think I can arrive of what is going on here. If this person, for example, was drinking a lot of water, maybe they were drinking a bucket of water per day, what do I expect their urine osms to be? I expect their urine to be too dilute. It shouldn't be normal. It should be too dilute. So if this is normal, maybe this is not uh, um, this is not primary polydipsia. From She's not peeing a lot because she's drinking a lot. I think that's not the case. And what am I remain with if that is not primary polydipsia? It's diabetes insipidus. In diabetes insipidus, what is troubling me to this to reflect on the data? What do I expect in diabetes insipidus? These patients, I believe they cannot reabsorb water properly. Yes, I believe that's the case. So how would the urine osms be? I think it should be what? How should it be? I think it should be concentrated. I believe. Yes, I think it should be concentrated. I believe it should be it should be concentrated, and then this person is normal. Now that would be troubling for me. I expected either a high or low, and I can be on a certain sense. But what I know for sure, if you are drinking a lot, your urine is very dilute. So if it is not dilute, if I'm about now to guess, I will lean to the side of the eye more than primary polydipsia. And yes, we remain with one aliquot. I believe the next aliquot we'll be talking about giving uh, a synthetic ADH to know if this is DI, is it from the nephron, or the is it from the brain? I believe that's what will happen, and I might prepare to interpret that. So if you give antidiuretic hormone and these people respond, it means the kidney is the problem. Sorry, that's wrong. It means the brain is the problem. They are not producing ADH. If you are giving ADH and it is not responding, it means their kidney is the problem. It cannot sense the ADH. In what other ways would I be wrong? Because I don't see any other diagnosis there. It is not a solute, should be water diuresis. And if it's water diuresis, primary polydipsia, and DI on the other hand, yeah, I believe I'm on the right line. So if this is DI, what is causing this to be difficult for this patient? We are told they don't have head injury. I'm seeing the medication. I've read some cases like this, and what I know you should probe from the medication is something called lithium, which I don't think if it's given in this country, because the last time I rotated in psychiatry, I didn't see that to be the practice. But what I read from other cases is they keep asking about even a previous history, not even a current. You ask previous whether they had a mental problem and they were given lithium. Lithium can cause a nephrogenic DI. Or other things, maybe they can image their brain and see what's happening to their pituitary. Yeah. So I'm on that line, David.
Okay. Thank you very much, Joseph. I think that's a lot of progress. I mean, given a presentation of polyuria and polydipsia, I believe most of us would be stuck after after finding that there is no diabetes. So I loved your approach from the word go. That so I rephrased the presenting complaint. It was actually written. So the case summary was an 80-year-old with polydipsia and polyuria, and the way you approach the increased the frequency of urination, considering that probably there is an irritation in the urinary tract. So thinking about a UTI or something of that sort, which was in the case. And then I went on to discuss about a volume problem, and then approaching it from that angle that it could be water diuresis or it could be solute diuresis. And then for solute diuresis, there are things like glucose, so diabetes mellitus, which I think most of us would think about. And then if it's not present, I think would be back to square one. Then other solutes like mannitol, uh, hypertonic saline. Maybe I think an addition could also be, I believe, calcium. If someone
Yeah,
has
sure.
hypercalcemia, they also present with polyuria. So calcium will be another solute there. And then there's a water issue where you talked about primary polydipsia, and then diabetes insipidus, where there's nephrogenic as well as central DI. So I think the differential was quite extensive. Uh, and I believe all of us got something to learn from the meticulous way you approached it. And then the other thing is the way you discussed the labs. I mean, if we talk about a reference range of glycated hemoglobin between 4 and 6, and then this patient's HbA1c was 6.4. So I think it needs someone to be very, very familiar with guidelines, not to be misled that, okay, we are probably dealing with diabetes here, because I think the cutoff should be above 6.5, right?
Yeah.
In someone who is presenting with symptoms. And then if it was above 6.5, then we could be talking about diabetes. But then I see that didn't disturb you. So, and I see your knowledge about diabetes insipidus is quite extensive, because you also talked about synthetic ADH, which could help localize the problem, whether it's a nephrogenic or central. Um, so I think in an ideal setting, you'd have been able to make the diagnosis, and so you are in the right track. So on the last early quote, they didn't talk about ADH, but they imaged the brain. So they did MRI brain, uh, and so there was a 1 centimeter diffusely enhancing nodular soft tissue mass along the posterior aspect of the sella,
Mm.
which was worrisome for a posterior pituitary mass. And so the final diagnosis was central diabetes insipidus.
Mm.
So I'll read the teaching points and then come back to you for reflections. Yeah, so on case resolution, this patient was referred to a neurosurgeon who specializes in pituitary tumors. She was started on desmopressin um, with desmopressin 0.2 milligrams daily. So that was the synthetic ADH we're talking about. And there was complete resolution of polyuria and polydipsia. So after her MRI showed the pituitary lesion, she had a serum checked for the following hormones: ACTH, which was 15 within normal limits. Prolactin was 17.98, which also seems to be within normal range. Cortisol was 8.4. Follicle stimulating hormone was 30.3, which was also within normal range. Luteinizing hormone was 10.29, which was slightly low, because for postmenopausal women, the reference range is 10.87 to 58.
Okay.
So she's currently awaiting surgery. On pathophysiology, central diabetes insipidus is characterized by decreased release of antidiuretic hormone, also called arginine vasopressin, that is AVP, resulting in a variable degree of polyuria. Lack of ADH can be caused by disorders that act in one or more sites involved in ADH secretion. The hypothalamic osmoreceptors, the supraoptic or paraventricular nuclei, or the superior portion of the supraoptic hypophyseal tract. On clinical presentation, untreated central DI patients present with polyuria, nocturia, and polydipsia, which is stimulated by increasing serum sodium and osmolality values. Most patients will have a normal high level of serum sodium. A moderate to severe hypernatremia may develop when thirst is impaired in instances such as additional CNS lesions, in infants and young children who cannot independently access free water, and in the postoperative period in patients with unrecognized diabetes insipidus. Diagnosis: fluid restriction for a period of several hours or overnight, depending on patient characteristics and severity of polydipsia, while periodically measuring serum sodium, serum and urine osmolality will provide the diagnosis. Serum sodium concentration at 145 and osmolality 295 to 300 is sufficient enough to stimulate ADH release to maximally concentrate the urine in normal subjects. The goal of water restriction is to achieve a serum sodium concentration of more than 145 and serum osmolality of more than 295. If urine osmolality is less than 700, the diagnosis of diabetes insipidus could be made. Exogenous ADH could be administered at this point to differentiate central or peripheral causes. Now, on causes of central DI, you have idiopathic, which is the most common, pituitary tumors, infiltrative diseases, familial and congenital diseases such as familial central DI, Wolfram syndrome, which is diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, congenital hypopituitarism, and septoptic dysplasia. So one teaching point on acute onset of polydipsia and polyuria in an adult patient should raise the suspicion of DI. After other common causes such as hyperglycemia with glycosuria, medications that promote diuresis, and surreptitious polydipsia ruled out, a simple patient fluid restriction test for few hours while measuring serum sodium, the osmolality of serum and urine can be very helpful. Yeah, so that's it about the teaching points. Back to you, Joseph, for any reflections before we open the floor for any questions or comments.
Yeah, thank you very much. You have chosen such a nice case because, so yeah, one thing that I didn't know here is when they talked about, I expected, uh, because in their presentation they said the urine osm was within normal limit, eh? And then even the sodium was within normal limit, the serum sodium. But in the teaching point, they're telling us is 700. Yes, so if that was not the difference in the case, so it should have been low. Yeah, I think maybe that. Yes, and thank you. You have added some things. Yes, calcium. I don't know why I forget, but yes, people's hypercalcemia that we present to is high polyuria with constipation. This side is producing a lot. This side is not producing, and other things. Yeah, those causes of central DI, very nice. I learned them. What I know is the water restriction tests from.
You are breaking, Joseph.
Ah, hello.
Yes, maybe you can you can repeat a few points that you made in the last few seconds, and then
Yeah,
we proceed from there.
yeah. I don't know where I ended, but I said yeah. I've learned well from these causes of central dehydrats are producing calcium, very nice, and what I know is from my reading is the water restriction test is like it's prohibited to be done. I don't know, but I think I could go and learn more. But I remember reading that. So much of what I was saying here is I learned when I saw the when I was rounding the ICU with Kiara back then, and we saw a patient with that guy was young guy producing like 6 liters of urine, and he was lying there in the ICU convulsing from hyponatremia. So yeah, I think I don't have much to add.
Thank you very much, Joseph. I believe, just like I said a, a few minutes ago, that I believe most of us have learned something today approaching a patient with polyuria and polydipsia. So I believe we have added some differentials and some pearls on how we can approach these patients. So I think we still have some time. So I open the floor if there are any comments, any questions, anything before we close the session. I do not see any hands. If someone has anything, you can just unmute yourself and speak. Uh, I think we still have a few minutes before time is up. So
People are still processing the case probably. Um,
yeah, I do not see any hands. But so if anyone has anything, you can stop me at any point and air out your thoughts. But I think so. I personally I learned very much from your approach, Joseph, today, and I think everyone will agree with me that I think we everyone enjoyed your discussion, and we can't wait for more. So I think I'll come up with a real case that was seen in our setting next weekend, and people will have more of Joseph. I believe for the past, I'm not sure how many months, people have just been hearing my voice discussing cases.
which was very fun.
So but it went on for a long time, and I think people need to get something fresh. So I think for the next couple of weeks, we'll hear from Joseph back to back before he prepares some more cases and switch back to me and someone else. So we do not want this to be very monotonous. So we encourage others who are ready to volunteer and discuss cases, because it's just all we need is to share part of ourselves. So this is a thinking out loud protocol is uh, different from something like driving or playing chess, where you can teach some very basic principles that you should do this and this. Teaching clinical reasoning is very difficult, but I think one of the best ways that can approach the ideal is to show people how you are thinking. So we welcome everyone who is ready to share with us the inside of their brains, how they are thinking. I think that is one of the greatest gifts that you can give to others, is to share how you are thinking. So I believe in days to come, while Joseph is still discussing these cases, someone else will be inspired volunteer and discuss the cases. So we are very much looking forward to that.
Sure.
Yeah, I do not see any hands up to this point. So uh, just to emphasize a few things is we are practicing and we see very interesting cases. They're actually very interesting cases in our everyday practice. So all we have to do is you do not need to have slides, just like you saw we presented today without slides. So if you have a case that you wish to share with us, whether it's a finished case or an unfinished case, you can just reach out to any of us, whether Joseph or me, and we can discuss that case. I think even if it's an unfinished case, I think that could be value added for the patient. If it's a case that has been worked up to a certain point, maybe we can have some inputs which can help arrive at a diagnosis or proper management for the patient.
Sure.
So, and the case doesn't need to be very difficult. You've seen here we've seen cases of just hyperuricemia, for example, tuberculosis,
Malaria.
inflammatory bowel disease. So generally, they do not have to be those rare syndromes. We just need a case that can stimulate our thinking and uh, hopefully add value for the patients. So prepare your cases, share with us so we can have a vast library to discuss cases from. So I think our goal should be from this time onwards is not to use human DX very frequently, although yes, it has very nice cases, but we would love to have more cases from our daily practice.
Sure.
Yeah, so if I do not see any hands up to this point, I'd like to thank everyone for joining, and I believe everyone enjoyed listening to Joseph. So make sure you do not miss this next weekend, because I think the case will be even more interesting. You will have much more to learn from him. I was told I was telling you always that when Joseph discusses, that will be a landslide. So I think everyone has proved it today. So do not miss next weekend. We'll share the link. Join on time and encourage others to join. I think uh, medicine is very broad, as we've seen today and many other days, and we need to be lifelong learners. So let's keep learning.
Sure.
Okay, I like to wish everyone a good night. See you next weekend.
Good night.